Thank you. Thank you very much. I think it's more important for you to see the screen than myself. I will try, and thank you, IIS, for asking me to put in 15 minutes 4 days of conference in Munich. So this task will be a little complicated. I will not enter in detail in every of these topics, but I will try to touch base in some of them. Every time that we hear about one patient that was cured, we are full of hope that this will happen very soon. It's a very good news for everybody. And a new cure case was presented in IIS. This is the 7th person to be cured. All of the previous person cured were through the transplantation of a stem cell. The majority of the previous transplantation were patients that received a stem cell from people with a specific mutation, the Delta 32, that provide resistance to the infection because this gene is the one that codes the CCR5 that is critical for showing the CD4 with the HIV. The news in this patient, or the novelty in this patient, this is an heterozygote, wild-type Delta 32, so opening more opportunities for transplantation and hopefully having more patients cured. But as you know, to do a transplantation is a very risky procedure and very expensive, and it's only limited for people that had the need of the transplantation because leukemia or lymphoma, etc. In the conference also was more information about another patient, the Geneva patient. This is the only one in the world that has received a cell without this mutation, the wild-type CCR5. And nobody really knows why this transplantation function and why this patient is cured, but maybe a lot of graft versus host diseases episodes, more than 6, resulted in clearance of the virus. So that we continue looking for different ways to rid of HIV, and we will not enter in detail. There are neutralizing antibodies. There are some adenovirus-associated vectors that integrated some episomal DNA to produce antibodies, and there is also this nice CRISPR technology that cut the integrated HIV in latent infected cells. But all this is very an early stage yet, and we will continue waiting for some good news in the next conferences. But the most important news in the conference was the result of the Purpose 1 study. This is a study in 5,000 women in Africa. They were receiving PrEP. 2,000 received tenofovir, TAF emtricitabine. 1,000 received tenofovir emtricitabine, and 2,000 received lenacapavir, which is an injection that is given twice a year. 0 infections in the lenacapavir arm. So, and this result were later reinforced by the Purpose 2 study that was presented in Lima, this time for men having sex with men and transgender women, 96% efficacy. So it's tremendous good news. It's like a vaccine, you know, it's a prevention, it's an injection every 6 months. STI has gained a lot of attention. There is no evidence that PrEP program increased the risk of STI, but the PrEP program are critical to put in evidence all the STI that is circulating. And there are many studies proposing doxycycline 200 milligrams during the next 72 hours after the last exposure to reduce the incidence of some STI, in particular syphilis. But in the conference, they presented also 2 pilot studies in doxy PrEP for those patients that has a lot of sexual activity. So it's more convenient to take the half of the doses, 100 milligram every day, and this resulted in a reduction of 80% of syphilis among men having sex with men and 67% among female in Japan. This is the first study in women showing efficacy of doxycycline as preventive of syphilis, prevention of syphilis. This study in Mexico is interesting. They look at retrospectively what could have happened if 324 of their patients they were caring for had been tested for antigen for histo, crypto, or tuberculosis the day they were diagnosed with advanced HIV infection. Instead, they followed the standard of care and they recovered the information. And if they had had those tests, they could have saved $241 per patient, just avoiding unnecessary confirmatory and additional tests or longer hospitalization for those procedures. Many doctors doesn't prescribe rifampicin isoniazid because concern about the efficacy with dolutegravir or the interaction with dolutegravir. And this is large study, 1,500 participants in Thailand, half of them with efavirenz, half of them with dolutegravir without additional doses. And also they have half receiving daily isoniazid rifampicin 1 month daily or weekly during 3 months. Very good safety profile, very effective, no impact in the antiviral efficacy of dolutegravir, more than 93% viral suppression in different groups, and very good PK data. Although it's true that for 1 month daily, the area under the curve is a little lower, but still is over the IC90. A lot of information in the conference about the benefit and the successes of the transition to dolutegravir. 1,200 children from 0 to 18 years old transitioned to dolutegravir, 90% of suppression, which is incredibly high for children, as you know, with very few failures and very few adverse events. Uganda showed how they transitioned to dolutegravir, 1.2 million people, with an increase in the virological suppression to 96%. And more information about the probability that it's not needed to switch to sidobudin with somebody failing to tenofovir. This is adding more information to the result from the NADIA that we already heard before. But this, in this case, is the D2 study and the Vicen 144 weeks result that show that dolutegravir, patient failing to tripla will switch it to dolutegravir 3TC tenofovir or TAF or the standard of care, which is lopinavir, atazanavir plus sidobudin 3TC. What we learn from here is that this arm, the traditional classical WHO recommended previous regimen is not working well and accumulate more resistance than the switching to dolutegravir, tenofovir, and emtricitabine. So the results support the phase out of sidobudin, the phase out also of lopinavir and atazanavir, and replace this protease inhibitor for darunavir at lower dose. The REPRIVE study demonstrated that patients with HIV can benefit of receiving a statin. In particular, if they have moderated cardiovascular risk, they will have a 35% reduction of cardiovascular events. In this poster, the author wanted to know if abacavir was associated or not to this finding. And they found that the prior use of abacavir had a 50% higher incidence of some cardiovascular event. So again, let's try to use tenofovir instead of sidobudin and instead of abacavir if not necessary. But there are some patients that cannot receive tenofovir, and so there's a lot of use of TAF, and the TAF can be associated with an increase in the weight. So this good study from the Spanish from Spanish investigator, they switched undetectable patients that were receiving any different regimen, but without previous use of dolutegravir or bictegravir. They randomized it to dual therapy, dolutegravir 3TC, or bictegravir which is with emtricitabina, tenofovir, alafenamine. And you see here the efficacy is the same. There is no virological difference, but Biktarvy was associated at an increase of weight compared with dual therapy, in particular among those participants that were receiving tenofovir at baseline before the switch. There are a lot of gaps, probably the most important, although there is a lot of progress in the Caribbean, is the mother-to-child transmission. We still have in Latin America and the Caribbean coverage lower than some parts in Africa, and so we need to make an additional effort to reach all the women that need this prophylaxis. And also we need to close this gap that is every time is doing greater between the antiretroviral coverage among children and adults was quite small in 2013 and is increasing. This plenary, if you can see the recording, is beautiful, and Dr. Turkova in one of the plenary sessions, the most important plenary session. And the closing session was by Dr. Winnie from UNAIDS. She made a very strong call for ensure the accessibility and affordability of lenacapavir. And in the conference also, some data about the pricing was presented. Remember, in the US, this drug is $40,000 a year. It's being used for multi-resistant patients only at this time. But in the conference, there was a modeling that estimates that if we produce generics at large scale, the cost can be reduced to $40 to $100 a year. So a lot of effort needs to be put on this. Kevin mentioned stigma and discrimination, and it's very important to educate healthcare workers, doctors, nurses, because less than 50% has a clear understanding of what means U equal U, PrEP, or PEP. And this lack of understanding translates into excessive protective measures, like using 2 gloves instead of 1, or directly in discrimination, no wanting to care for some HIV patient or some patient that could have HIV. Another big survey among 800,000 users also shows that this discrimination is associated with, obviously, reduced uptake of antiretrovirals and reduced viral suppression, or higher community viral load. The conference was also a platform to show what is happening with the criminalization, in particular in Africa, when some countries are putting new law to penalize LGBTQ people or homosexuality. This is the case of Uganda and Ghana, but also was the case of Zimbabwe that presented they could repeal an old law that criminalized HIV because they could demonstrate that this law had a strong negative effect in HIV prevention. And this law that was intended to protect women was really creating a big problem. Finally, they showed that they need to work with the people, with the public hearing, and the legislative people in order to create this need to demand creation for repealing criminalization law. I need to acknowledge also the presence of the Caribbean. There was a good presentation from Haiti. Unfortunately, Samuel couldn't be there, but was presented by Paul Sachs. People from Dominican Republic presenting the intervention for risky behavior, and a beautiful presentation from Jamaica showing the 30 years of epidemics in the country. In conclusion, at the AIDS conference, the hope for the cure continues. However, the revolution in HIV prevention will be lenacapavir if it is affordable. The PrEP programs reveal the STI epidemics, but doxypep and doxyprep could help. The package for advanced HIV disease is cost-effective and maybe even cost-saving in some countries. The rifampicin isoniazid 3 months is safe and doesn't require an increase in the dose of dolutegravir. The optimization of antiretroviral should continue, eliminating raltegravir 400, eliminating lopinavir, eliminating atazanavir, and introducing darunavir in the co-formulated 500 milligram of ritonavir, and probably the co-formulating TAF for some specific patients. It is probably that we will be stopping soon. We will be stopping the use of sidobudin 3TC. We expect the next year WHO will be reviewing the guidelines. Dual therapy with 3TC dolutegravir might result in lower weight gain than Biktarvy. The cardiovascular risk associated with abacavir highlight the need to optimize cardiovascular prevention, and we must continue advocating for increased access to drugs, reducing stigma and discrimination, eliminating criminalization, because only political will and collective action can make this promise a reality. Thank you very much.